over the years, I have found that there are two classes of people that come to us. The first one is those that have predominantly hormone deficiencies with none of these symptoms at all. And the second group have tremendous amount of anxiety, depression, mood swings. They're just impossible to live with. Their sexuality has changed markedly, the relationships have changed markedly, and all of these are put into a category where I then evaluate whether or not this is completely related to hormone deficiency, or is there previous trauma, previous dissociation, previous issues that need to be dealt with separate from hormone replacement therapy. So I have a way approaching it very simply, and that is that when these symptoms develop, I usually reevaluate the patient in 6 weeks. And in 6 weeks' time, the hormones have done what they do, and what's left is very important to discern whether or not indeed they need psychotherapy, or whether or not they need just to understand that this is something they've lived with their whole life and they don't want to do anything about it, or they don't have to do anything about it. But those that do, we have Dr. Siegel, who then gets the referral from us. He does not take patients just straight usually. He usually gets a medical clearance, because I usually go through a process whereby I try my best to make sure that these people will be helped by a psychotherapist and do not require psychiatric medication. A second aspect of dealing with anxiety, depression, post-traumatic stress disorder, and hormone therapy is that so many of our patients, because of hormone deficiencies, are placed on psychotropic medication, anti-anxiety medication, sleeping pills. I have patients sometimes that come in with 4 or 5 prescriptions. They feel terrible because they don't have a Wellbutrin deficiency. They do not have a Xanax deficiency. They have hormone deficiencies. So the doctors sometimes will treat the symptoms because it's easier to write a script than it is to actually sit down and talk to the patient and get a history. So when we evaluate a patient in our practice, and we've been doing it for years, it's very important that the patient feels comfortable with us. So we really are pretty good, I think, at getting a rapport almost immediate with the patient. They feel comfortable telling us what their life story is. And in that life story, I watch the patient very closely, because there are certain things that patients do when they're thinking about previous memories, previous traumas, previous events that are causing the anxiety. And they tend to look to the side, they usually look to the left, and they usually are looking at a picture. And that picture is coming from the subconscious. I refer you to another video which we made with Dr. Siegel that does relate to what's that process and why it presents itself as pictures. And I asked the patient, what are we looking at? And almost invariably, they're looking at the original trauma. It could be when they're 11, it could be they're 9, it could be when they're 21. But it is amazing to me that they know exactly what they're looking at and whether or not that was the source of anxiety. So in my practice, I tend to try to separate out the patients that really do have an understanding of what that is, which is most of the patients, and those that would require psychotherapy, which I do not do. As far as hormone replacement therapy goes, I will tell you that 90% of the patients who are on medications eventually get off the medication because they're not needed. Treating symptoms is not the way to go. It's always better to look at the etiology of a problem and treating the cause. Therefore, hormone replacement therapy is first, psychotherapy and other therapies are second.